Hello everyone, nice to meet you. This is Mylin from the Respiratory Department. Today, we will learn a new disease, chronic obstructive pulmonary disease. For short, that is COPD. And in Chinese, we call it 慢性阻塞性肺疾病. The contents of this class include introduction, clinical manifestation, auxiliary examination, diagnosis, and treatment. And finally, we will have a case discussion. Please pay attention to the case discussion. Maybe you will meet similar case in your final exam. Okay, firstly, let's move to the definition. COPD is a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. The cause is significant exposure to noxious particles and gases. The definition is complicated, right? But I think we can find some keywords. The first keyword is chronic. That means the COPD patient usually get persistent respiratory symptoms for more than 2 years and more than 3 months per year. 2. Obstructive. That means the small airway narrowing is the most common change in COPD and is also the basic change in pathology. 3. Pulmonary. If the small airway narrowing exists for a long time, the airflow limitation will cause the enlargement and damage of the alveoli and results in emphysema. 4. It's about the cause. The most common cause of COPD is the noxious particles and gases, including smoking, smog, and cooking fumes. Please pay attention to the cooking fumes because it's the most common cause for the female patient of COPD. How did the COPD occur? There are 3 factors, and this area is COPD. The D is the typical COPD. And what are ABC? A is the chronic bronchitis. B is the emphysema. C is the air limitation. Let's look at them one by one. A. Chronic bronchitis. From these words, we can find some key points. Point is chronic. That means chronic bronchitis or COPD must occur after exposure to the risk for a long time. For example, if a patient smokes for more than 10 years, he is likely to get COPD. But another patient smoked just for 1 month, we cannot suspect a COPD at first time. Another key point is bronchi. That means the inflammation occurs in bronchi, but not in trachea or alveoli, so that we can hear wheezing rail during auscultation in both lungs. Another key point is about the inflammation. The inflammation in COPD or chronic bronchitis is non-specific one. There are 2 types of inflammation, non-specific and specific, and there are several differences between these 2 types of inflammation. For the specific inflammation, the cause must be microorganisms, so that we choose the antibiotics for therapy. But in COPD, the non-specific inflammation is caused by dust and particles, so that we have to choose glucocorticoid, but not antibiotics for therapy. Now let's look at two pictures. The first picture shows the normal bronchial epithelium. We can find here are the normal epithelial cells of bronchi, the coronal epithelial cells, and their cilium. But in COPD, there are some changes in epithelium. We can see here, there are the proliferation of goblet cell and the proliferation of the connective tissue. These changes will finally result in the mucous hypersecretion and airway narrowing, as this picture showing. B. Emphysema. Emphysema is the result of mucous thrombus and airway narrowing. Let's look at this picture. We can see here, those feriform change are the emphysema. And what does it look like under the microscope? Let's look at this picture. This picture shows the integrated alveoli in the normal lung. But in COPD, we can find lots of alveoli are damaged here. And this damage of alveoli will finally cause emphysema, which will induce gas exchange abnormalities, the airway limitation. If the airway limitation become more and more severe, and the patients are likely to get dyspnea. In this condition, we need a spirometry to confirm the diagnosis of COPD. This picture shows the spirometry examination. We can see a patient sit on a chair and use his mouth to do respiration with this machine and without nurse respiration. And finally, we will get a report as this one. And how to diagnose the COPD? We can find the diagnostic criterion is FEV1 over FVC less than 70%. Let's try to find the data. FEV1 over FVC here, and the measured data is 67.64%, less than 70%. So, according to this report, we can diagnose COPD. In this figure, we can find that more than 1 in 10 of the people over 40 years old suffer from COPD. And the morbidities of COPD is associated with age, comorbidities, and combining disease. For now, the COPD is the second leading cause of death in China. So that it's very important for us to pay attention to the prevention, early diagnosis, and early therapy for these patients. And now, let's move to the clinical manifestation. You can find that a lot of symptoms and signs described in your textbook. It's complicated, right? But I think we can try to find some methods, such as dividing them into different groups. It's much more easier for us to keep them in mind. Symptoms of the COPD can be divided into two groups. The first group is the main symptoms, including the cough, sputum, and dyspnea. The cough must be chronic. Most of the patients will got cough for more than 2 years and more than 3 months per year. And most of them will got more severe cough in the morning and in the spring or winter while the weather change. Why we need to describe the details of the symptoms? Is it important? Yes, it's very important for us to describe the characteristics of the symptoms. According to the details, we can exclude some differentiate diagnosis. For example, if a patient got cough for several years and he feel more severe in the evening and in spring, especially when he inhaled some fumes or dust. What's the suspected diagnosis for this patient? Is it still COPD? No, it's not COPD because the details of a cough is not fit COPD. And finally, the suspected diagnosis of this patient is asthma. Another symptom is sputum. The sputum is white, thin, and small amount because the sputum is produced by goblet seal. About the dyspnea, we need to focus on the activity. For example, if the patient feels dyspnea only after running, we can suspect a mild dyspnea. And if another people feel dyspnea when he is wearing clothes or eating, in this condition, we can suspect severe dyspnea, so that the characteristics of the symptoms can be also associated with the severity of the disease. The second group of symptoms is the symptoms induced by comorbidities. For example, if the patient got pneumonia combining with COPD, the patients are likely to get fever and yellow sputum. And if the patients got copamidine combining with COPD, the patients are likely to get edema in lower limbs and poor appetite, and so on. So, that is the second group of the symptoms. The signs of COPD can also be divided into two groups. The first group is about the thorax and lungs, including the inspection, palpation, auscultation, and percussion. During the inspection, we can find the barrel chest and distension of the intercostal gaps. And during the palpation, we can find the decreasing of the parameters and the thorax expansion. And in the percussion, we can find the percussion sound change. During the auscultation, we can find the decreasing of the breath sound. All of these positive signs above is caused by the emphysema. And sometimes we can hear wheezing rail in both lungs. That's because of bronchospasm. So that once we hear the wheeze, we can suspect acute exacerbation of COPD. And sometimes we can also hear crackles. The crackles means that there are some fluid in lungs. So, we can suspect acute inflammatory exudation in lungs. for example, pneumonia. Another group of the signs is associated with the comorbidities of COPD. Let's count them from the top to the bottom. The first one is the chemosis, which caused by the retention of carbon dioxide. As the picture showing, we can find the eyes of the patient is red and with tears. It looks like this patient is just crying. And that's because the vessels of the eyes is extended by the high level of the carbon dioxide. Another one is the cyanosis, which caused by the hypoxia. About the neck, we usually can find the expansion of the jugular vein caused by the cor-pulmonale. And sometimes, if we find the displacement of trachea, we can suspect a pneumonia with COPD. About the heart, maybe we can find the enlargement of the right heart and increasing of the sound tube in pulmonary valve area, which caused by the cor-pulmonale. Sometimes, maybe we can find the finger clumping, which caused by the dyspnea for a long time. And about the edema, maybe we can find edema caused by the cor-pulmonale or DVT, deep venous thrombosis. And that's the signs. Okay, let's move to the auxiliary examinations. Once we collect the information of the symptoms and signs during the inquisitions and physical examinations, there will be a suspected diagnosis. And next, we need to arrange some auxiliary examinations to confirm the initial diagnosis and to evaluate the severity of the disease. Let's move to the radiologic examinations firstly. For the COPD patients, we usually choose X-ray or chest CT scan for them. Okay, let's look at the first pictures of the chest X-ray. In this picture, we can find that the image of the left lung is much more black than the right lung, and that means the density of the left lung is lower than the right lung. And according to the image of the left lower lung, we can suspect the emphysema. And about the CT scan, there are two types of the CT scan for COPD patient. One is the low-dose CT. As the picture showing, we can find the density of the two lumps decreasing. And according to this image, we can diagnose emphysema. But sometimes there will be a missed diagnosis because we can find the same image in some normal people because of the inappropriate exposure. In this time, we need another type of the CT scan, that is HRCT, high resolution CT scan. As the picture showing, we can find lots of black round area in both lungs. Those are the emphysema. So, according to these three pictures, you need to remember that the X-ray or low-dose CT is not clear enough for emphysema, and the HRCT is the best radiologic examination for emphysema. Let's look at another two pictures. This picture is the same to the first one. As the red arrow showing, we can find a black area is much more black than other area in the left lung. And in CT scan, we can find some round black area with thin walls. Those are bullae, caused by the confusion of the emphysema. And in this X-ray, we can find some unclear opacity with increasing density in both lower lungs. Those are the chronic bronchitis. But once the patient receives CT scan, maybe we can find pneumonia in both lungs. And now, let's move to the most important examinations for the COPD patients. That is spirometry. Firstly, let's look at the items in the spirometry. The first one is the FVC, forced vital capacity. We can ask the patient to do deep inspirations and after that to do the forced expirations. The second one is FEV1, means the forced expiratory volume in the first second. And the FEF means forced expiratory flow. And RV means residue volume. Please notice here, all of the predicted values based on the age, height, sex, and race. So, in different patients, the predicted values are different too. And now, let's look at the spirometry report for the COPD patients. We can find that the decreasing of the FVC and FEV1, especially in FEV1, so that we can find the FEV1 over FVC decreasing too. The data is less than 70%. It's also the diagnostic criteria for COPD patients. Others, we can also find the decreasing of the FEV1 in PREDICT and PF 50 and 75. Those data means the small airway narrowing. And finally, we can find increasing in RV shows the emphysema. According to the decreasing of the FEV1 in predicted, we can evaluate the severity of the airflow limitations in the COPD patient. As the table showing, we can divide the COPD patients into 4 groups. GOLD 1, mild. GOLD 2, moderate. GOLD 3, severe. GOLD 4, very severe. According to the data of the FEV1 in PREDICT with 80%, 50%, and 30%. And here, please notice that we only do these evaluations in patients with COPD. That means in patients with FEV1 over FVC less than 70%. It's no meaning to do these evaluations with patients for the patients without COPD. And 2, we need to do these evaluations based on the post-bronchial dilator value of FEV1. That's very important. In the spirometry report, we can also find the VV curves. The full name is the flow velocity volume curves, as this figure showing. In this figure, we can see 2 axes. The vertical axis is the flow velocity, and the horizontal axis shows the volume of the lungs. This curve shows the curves in the normal patient. And what will change in COPD patients? Let's have a guess. Firstly, let's try to recall that the COPD patients usually get expiratory dyspnea, right? So the PEF will decrease. Let's mark here. And about the volumes, we can see that the patients of COPD will get a decreasing of FVC. So the volume of the lungs also decrease too, and we can mark here. And now let's connect these points to get a new curves. That is the VV curves of the COPD patients. And now let's do an exercise. Here is a case. Here is a man, 5-6 years old, smoking for 3 years. The chief complaint of these patients is the cough sputum for 5 years, dyspnea for 6 months, turning worse for 3 days. From this medical record, we can be informed that these patients are with the history of long-term smoking, and the symptoms including the cough, sputum, and dyspnea. According to these informations, we can suspect the diagnosis of COPD. And next, we need to arrange spirometry for these patients. Let's look at the report. Here shows the VV curves of these patients. We can see here the VV curves is similar to the VV curves of COPD. We just talked about that. So we need further analysis of the data. Firstly, we need to confirm whether the patient suffers from COPD. We can look at the FEV1 or FVC here. It's the diagnostic criteria for COPD. And after using of the bronchodilators, we can find the data is 32.67%, less than 70%. So we can diagnose the COPD. And later we need to look at here the FEV1 in predict. And after using of the bronchodilators, you find the data is 31.09%, between the 30% to 50%. And finally, we can conclude that the spirometric findings shows the severe obstructive ventilation dysfunction, and the diagnosis is that chronic obstructive pulmonary disease, GOAT 3. About the other findings, the other findings include the laboratory tests and some special tests. All of these findings are about the comorbidities of COPD. For example, if the patient got pneumonia with COPD, we need to do some blood tests for these patients. And in this condition, maybe we can find the increasing of the count of the WBC and increasing of the CRP, ESR, and PCT. We can also arrange chest X-ray for scanning the pneumothorax, and ECG echo to scan the core pulmonary, and ABG arterial blood gas analysis for scanning the respiratory failure, and CT scan tumor markers biopsy for scanning the lung cancer. And before we start the therapy for this patient, we need to confirm the liver function and kidney function for these patients so that we can choose appropriate drugs for the patients. Here, please pay attention to these special examinations called 6-minute walk test. This test is a free examination to evaluate the function of pulmonary and heart. Generally, the systematic diagnosis of a disease includes 3 steps: to confirm the initial diagnosis, to assess the severity of the disease, and to search for the comorbidities. Step 1. To confirm the initial diagnosis. According to the symptoms, especially the main symptoms, including the sputum, cough, and dyspnea, plus the risk factors, including the exposure to the noxious particles and gas, we can suspect a COPD, and that is our initial diagnosis. And next, we need to arrange a spirometry for this patient to confirm our initial diagnosis. The diagnostic criteria of COPD including 2 points. 1. The post-bronchodilator FEV1 over FVC less than 70%. Here we need to notice the post-bronchodilator data. And 2. To exclude other differential diagnoses, including asthma, lung cancer, tuberculosis, left heart failure, and so on. How to build the regime of differential diagnosis? I think it's really a difficult question. Once I worked in the department, I found that many young doctors would like to do meaningless differential diagnosis for their patients. For example, they would like to exclude lung cancer for every patient, even though the patients are with no mass in their lungs. So, how to build the meaningful regime of differential diagnosis? Now, I will tell you 2 methods for it. 1 is according to the symptoms. For example, if a patient got chronic cough sputum for a long time, we can suspect COPD because the main symptoms of COPD is cough, sputum, and dyspnea, right? But we must think about that. What else disease will fit these symptoms? We can find that the asthma patients usually got cough or sputum, and so as to the tuberculosis, lung cancer, and so on. So once we diagnose a COPD according to the symptoms of cough and sputum, we need to exclude this differential diagnosis. And about the dyspnea, we can also find the dyspnea exists in the COPD patients. And what else disease can also fit this symptom? Yes, the asthma patients can also have dyspnea. And so as to the patients with interstitial lung disease and left heart failure. And that's the first method for differential diagnosis, according to the symptoms. Another method for differential diagnosis is according to the abnormal findings in auxiliary examinations. For example, if we find the bronchitis in lungs, we can suspect chronic bronchitis or COPD, asthma, and some obesity. All of these diseases can present the same change in the X-ray. So that's the second method for differential diagnosis. Once we confirm the diagnosis of COPD, we also need to confirm the stage of COPD in chronic stage or in acute exacerbation stage. The acute Once we confirm the diagnosis of COPD, we also need to confirm the stage of this disease in chronic stage or in acute exacerbation stage. The acute exacerbation stage of COPD present exacerbation of respiratory symptoms triggered by the respiratory infection with bacteria and/or viruses, which result of increasing inflammation, hyperinflation, and gas trapping. The symptoms in acute exacerbation stage include increased dyspnea and cough, and sputum will turn yellow or become more and more, and sometimes with fever caused by the infection. Step 2. To assess the severity of COPD. The first assessment is about the severity of airflow limitation. We just talked about this before. In the table, we can see that the patients with COPD can be divided into 4 groups. Group 1, mild. Group 2, moderate. Group 3, severe. And Group 4, very severe, according to the data of FEV1 in predicted, with 80%, 50%, 30%, and less than 30%. Here we must notice that we can only do this assessment for the patient with COPD. That means the FEV1 over FVC less than 70%. It's meaningless for us to do this assessment for the patient without COPD. And during we do this assessment, we need to use the data of FEV1 post-bronchodilator. Okay, let's do an exercise. We can see in this spirometry report here FEV1 over FVC is less than 70%. And which group will this patient reside in? Let's look at here. FEV1 in predict is 66%. We can find that this patient is belong to Group 2, moderate. The second assessment for the COPD patient is to assess the symptoms. There are 2 scales for us to use, but the most useful one is the MMRC scale. Let's look at this table. The patients can be divided into 5 grades. MMRC grade 0 to 4, and it's complicated, but we just need to focus on the grade 2. The patient works slower than people of the same age on the level because of breathlessness, or have to stop for breath when working on their own pace on the level. MMRC grade is a very important factor for another assessment. That is the combined assessment for the symptoms and risk of acute exacerbation. Let's look at this figure. We can see there are two factors in this assessment. One is the MMRC. According to the MMRC grade, less or more than 2, the patients can be divided into Group A and C or Group B and D. Another factor is about the exacerbation history. The patients in Group A and B got less times of exacerbation history, and other patients in Group C or D got more times of exacerbation history. There are some tips for you to understand this assessment. First one, exacerbation of COPD will cause rapid decreasing of FEV1. So, we can find that to control the times of exacerbation is the most important goal for us for the treatment. And another tip is that frequent exacerbation histories are usually associated with high level of chronic bronchial inflammation. So, the ICS, that is the inhaled glucocorticoid, is required in just Group C or D. 3. Because of more severe dyspnea, one more bronchodilator is required in Group B and D than Groups A and C. Okay, we will talk about more details about the relationship between this assessment and the therapy. Later. 3. Because of more severe dyspnea, one more bronchodilator is required in Groups B and D than the Groups A and C. Here. And we will talk about more details about the relationship between the assessment and the treatment later. Step 3. After we confirm the initial diagnosis and finish the assessment of the severity of the disease, we also need to assess the comorbidities, including the pneumonia, pneumothorax, copulmonary respiratory failure, lung cancer, pulmonary embolisms, and so on. Here is the summary of the diagnosed steps. Firstly, according to the risk factors, signs, and symptoms, we can suspect a COPD. And then, according to the FEV1 over FVC less than 70% in the spirometry, we can confirm the diagnosis of COPD. And next, we need to do some assessment for the airflow limitation, Group 1 to 4, and assessment of the symptoms and risk of the exacerbations, Group A, B, C, D. And finally, we need to confirm the comorbidities of this patient.